I am pleased to welcome you in Anesthesia and ICU News. My name is Martin, and in today's session we will discuss renal replacement therapy. If you ever felt like it's a difficult topic, don't worry, I was there, every junior intensivist was there. I promise you that after watching this video, you will master all important concepts in this field. So let's get started. At the beginning, we should sum up some basics that you should be aware of, starting with acute kidney injury occurs in over half of our ICU patients, and around 10 to 15% will require some form of renal replacement therapy during their stay. Mortality in studies range from 25 to 60%, and consider that acute kidney injury score is independently associated with higher mortality. And when do you need to start renal replacement therapy? First, there exists some absolute criteria for initiation of renal replacement therapy. For junior doctors, these can be the stepping stones in their decision making. Indications include fluid overload, non-responsive to diuretic therapy, or in other words, in anuric patient. Somebody, for example, with pulmonary edema, anuric, and non-responsive to furosemide should be strongly considered for renal replacement therapy. Life-threatening hyperkalemia above usually 6.5 millimoles per liter is another situation. This should be, of course, in the context of clinical scenario and response to treatment. European Resuscitation Council in 2021 guidelines suggests consideration of dialysis above 6.5, but think about these as a non-strict cutoff, as different sources can have a little bit different cutoff. Consider possible rebound hyperkalemia, as potassium can and is stored intracellularly, and with renal replacement therapy we eliminate potassium from central vascular compartment only. Shift afterwards can happen and increase of potassium can be found again. Next we've got metabolic acidosis unresponsive to medical management. Value of pH under 7.15 is quoted commonly as a cutoff. Hypermagnesemia is sometimes stated because magnesium is eliminated mainly by kidneys. This can happen, for example, in severe cases of eclampsia, when acute kidney injury with low elimination is met with iatrogenic high doses of magnesium. Then there are uremic complications like pericarditis, encephalopathy, thrombocytopathy, and finally toxins, which are commonly asked on board exams, so it is worth remembering them. These molecules need to be small, polar, and have small volume of distribution, and when they are, they can be easily removed by renal replacement therapy. And always remember that more important than sole number is the response to the initial management and where the whole situation is heading. Imagine a patient that does not meet the absolute criteria but is slowly heading towards them. In spite of all the previous approaches that were done right, like optimization of hemodynamic status, specific treatment and other supportive procedures that you've provided, this patient multi-organ dysfunction and acute kidney injury is progressing. In this situation, you should consider renal replacement therapy. This is of course a tough question, and don't hesitate to ask your senior colleagues. Dialysis is the most definitive treatment for hyperkalemia. European Resuscitation Council suggests consideration of renal replacement therapy in situations like end-stage renal disease, severe life-threatening hyperkalemia with or without ECG changes or arrhythmias, hyperkalemia resistant to medical management, oliguric acute kidney injury with urine output under 400 ml per day, and marked tissue breakdown, which can happen in rhabdomyolysis or tumor lysis syndrome. Acidosis that does not meet absolute criteria can be indication to renal replacement therapy, depend on the situation. In situations like hyperthermia, renal replacement therapy can sometimes be used in experienced hands to control body temperature. Worth remembering is that patients on continuous dialysis are continuously cool, so it means that they won't easily increase their body temperature in response to infection, for example. Hypernatremia or different electrolyte disbalances can be considered as an indication too. Of course, this is much less often. Okay, so you've decided that you want your patient on renal replacement therapy. Well, first you naturally need a good access to venous blood, ideally superior or inferior vena cava. Most recommended access is through the right internal jugular vein, as this vein is straight compared to the left version. Second option is to cannulate one of the femoral veins. They have straight trajectory, but on the other hand, they have increased risk for infectious complication. Subclavian veins are avoided as much as possible. Why? Even if the catheter can function properly for some time, it increases the risk of thrombosis or scarring of the vein and causing the vein to narrow, and eventually can jeopardize the possibility for future arteriovenous fistula on that hand. Remember that thrombosis is most likely to occur when the catheter has trajectory with angulations. The usual size of catheter is around 12 Frenches, consists of 2 lumens, one primary for suction with red color marking and one primary for return of the blood with blue color. I'm saying primary because the red or arterial lumen is more proximal and the blue or venous lumen of the catheter ends more distal. Due to this structure of distal cannula, recirculation occurs only in negligible amount. Significant recirculation can occur if you would connect these lumen reversely. This can be sometimes done on purpose, in case when the suctioning orifice lies directly to the vessel wall and simply does not aspirate blood. This can happen in hypovolemic patient or bad position of the dialysis cannula. One of your options is to rotate your dialysis cannula, and if this won't help you, you can try to switch proximal and distal port to try to aspirate from the distal opening. This will be for the cost of more significant recirculation, so lesser efficiency of your renal replacement therapy. Sometimes you can see catheters with additional third lumen that exit distally, so you have an additional line with which you can give medication that won't be cleared by renal replacement therapy immediately. And please don't get confused with the name arterial or red color. Catheter with both lumen is inside a vein. Filter as a part of dialysis machine consists of a numerous capillaries that increase the area of semipermeable membrane up to around 1.5 square meter. Filter patency and its proper function can be affected by many causes. Clotting is a problem that we try to prevent by using anticoagulation. Filter function can also be compromised due to adherence of proteins or cytokines to the membrane surface. This will ultimately decrease the efficiency of the filter. Excessive fluid removal and intravascular dehydration are a contributing factor to clotting. Filter can last roughly around 2 to 3 days, but this is just for you to have a better picture, just a rough estimation. If you are unsure what some of these terms mean, don't worry, we'll get through them soon. Let's move to the principle behind the elimination of the waste molecules that we don't want in the blood in our patients. There exist 2 principles. First is diffusion and second is convection. When you hear word dialysis or diffusion, connect these 2 together because they describe same mechanism and make similar connection between words convection and filtration. First, some similarities. Both of these principles use semipermeable membrane. This is a part through which the main job is done. There exist some differences between membranes with different permeability properties and immunogenic potentials. Efficacy of the renal replacement therapy depends on the characteristic of the membranes, which are diffusion coefficients, thickness, and surface area. But considering this in the terms of everyday ICU care, you will probably have some standard membrane with which you will be defaultly working, so we will not be changing these properties. Choosing a different types of membrane can have its own role in chronic dialysis programs. For your better picture, these membranes can be cellulose-based or synthetic. As the blood gets in the contact with the membrane, especially with cellulose-based, activation of inflammatory pathways can occur, and because of that, more biocompatible membranes such as synthetic-based are recommended. Blood flows on the one side of the membrane in both cases. This flow is provided by the roller pumps. Term effluent. What is it? Effluent is just a waste fluid produced during renal replacement therapy session. It is produced in both dialysis and filtration, but through a different mechanism. Now let's talk about the differences between these principles. First is the diffusion, which uses dialysis solution or dialysate that flows on the other side of the membrane. Because this membrane is semi-permeable, it allows diffusion of the waste molecule to be transported to the dialysis solution and eventually to the effluent. And this is driven by the concentration gradient, which is the main player in the elimination. Uremic toxins such as urea and creatinine will have a high blood concentration and are absent in the dialysate. Diffusion is very efficient in removing small molecules such as potassium, ammonium, and creatinine. It is less efficient in removing larger solutes and water. Countercurrent flow in filter further increases its efficiency by maximizing the concentration gradient. And note that dialysis solution is not in direct contact with patient's blood. Second one is convection. Solutes and water are transported together over the membrane by pressure gradient. Again, characteristic of the membrane are another determinants for the efficiency. Hemofiltration is more efficient for removal of water and large molecules like mediators in sepsis, which includes interleukins, TNF-alpha, complement, eicosanoids or platelet activating factor. But it should be stated that there is no evidence to recommend convective methods over diffusion in septic patients, and this immunomodulatory concept showed up today no mortality benefit in clinical trials. In pure convective methods, we don't use dialysis solution, which makes a problem that you can easily lose several liters of patient's fluids during few hours. So we usually need some kind of replacement fluid. This replacement fluid, on the other hand, will be in a direct contact with patient's blood. Now let's discuss some general terms you should be familiar with. The dose of renal replacement therapy is by convention expressed as the clearance of urea. Urea is not retained by the membrane in either hemodialysis or hemofiltration. The effluent rate, which we already know is the waste fluid, equals the clearance of urea and the dose of renal replacement therapy. So, in other words, effluent rate is the same as a dose. For obvious reasons, this effluent needs to be partially or completely replaced, otherwise body fluid losses will be too high. This is the situation mainly with the convective methods. Why it is of less importance in diffusive methods? Well, with diffusion or dialysis you have already dialysis solution in place, which eventually becomes the effluent. In this situation, the final effluent is made from dialysis solution and patient's fluids combined, so the fluid losses from the patient is not so high. But this is not the case in convective methods that does not have the dialysis solution, and we need to replace these enormous losses with so-called replacement fluid. Most bags are bicarbonate based. Importantly, you can choose between different potassium concentration. Be familiar what you have in your ICU. Maybe you have K0, K2, K4, and you can choose depending on what you are aiming for. Phosphate-based solution can be sometimes available as well to prevent hypophosphatemia. Remember that bags without calcium needs to be used when you are using citrate as an anticoagulant. To anticoagulation generally we'll get soon, don't worry for now, we'll get there. You have three options when or where technically you will administer this so-called replacement fluid. This is happening on the extracorporeal circuit, but this fluid is injected directly to the blood. Exactly where is stated from the point of view of the filter. It can be pre-dilution, which is before the filter, post-dilution, which is after the filter, or combination of these two before. Pre-dilution techniques will dilute the blood before capillary filters, leading to dilution of the blood that will be filtered, so the drawback is logically decreased efficacy of the filtration. With post-dilution, on the other hand, starting efficacy of filtration is much higher. However, consider that blood concentrates much more while passing through the capillaries of the hemofilter. This can lead to clotting of the capillaries and eventually decrease the overall function of the filter because fewer capillaries are working. To prevent this unwanted clotting, a filtration fraction of less than 25% is advised. And what is the filtration fraction? Basically, it's the analogous concept as in a Bowman capsule in glomeruli. It is the ratio of the effluent flow over plasma flow. In different words, is the fraction of the plasma that is removed from the blood during filtration. Could be seen sometimes on dashboard of the machine. Much more important is ultrafiltration. Practically, ultrafiltration says how much fluid the patient lost during the session. For example, you prescribe 4-hour session with 1 liter ultrafiltration. This 1 liter will be lost in the effluent and will not be replaced. So the patient's fluid balance after this session will be minus 1 liter. So we can see this in an oliguric anuric on fluid overloaded patients. My advice for you is to be familiar with your local protocols. Ask your nurses where you can find this number of the ultrafiltration, because this very number is the one of the most important ones for you. And keep in mind that with increasing of your ultrafiltration rate, you will cause much more hemodynamic problems for your patient. So increase this ultrafiltration slowly as the patient tolerates it. In hemodiafiltration, as the name states, both convective and diffusive mechanisms are combined. Note that during combined methods, dialysis solution is in place, so another replacement fluid may or may not be present. For fluid removal to achieve proper negative balance in our patients, the convection or ultrafiltration techniques are used, as it is more efficient to draw water. It uses negative pressure on dialysate side of membrane. For solute clearance, the diffusion principle is more efficient, dialysate and blood flow on the opposite side of the membrane in countercurrent direction. And now to the modalities of renal replacement therapy. We can choose between few of them based on the duration of the session. On the left we can see the intermittent one, and on the right are the continuous ones. IHD stands for intermittent hemodialysis. This modality uses both convection and diffusion. CRRT stands for continuous renal replacement therapy, and it includes several more specific modalities, as the name of each says. Finally, in the middle, we can see hybrid modality, sustained low efficacy daily dialysis, which combines features from both previously mentioned. For better illustration and comparison of these modalities, let's look at this table. Length of the therapy is quite straightforward, and the name of the modality is already spoiling what does it means. Continuous will run indefinitely until we stop it. Intermittent ones can be used several times a week, commonly every other day, just for a few hours. We can see that blood flow is a little bit higher in the intermittent modalities than continuous one. Important fact that you can keep in mind is that below the value of 80 mL per minute of blood flow, the risk of thrombosis is rising. This can be a problem in smaller patients with continuous modalities. When we look at the dialysate flow or the dose, we can see that the intermittent modalities are dramatically much more efficient than the continuous one. This comes with an important side effect of the intermittent hemodialysis, which can cause significant hemodynamic instability, commonly seen at the bedside as an increase in catecholamine need to maintain mean arterial pressure. Continuous methods provide much greater hemodynamic stability and are preferred in acute shock states, but on the other hand are significantly less effective. Please note that in the context of continuous methods, these doses should not only be prescribed but delivered in reality. And what I mean by this? If you have a patient on continuous renal replacement therapy and you decide to move the patient to the theater or city, for example, you will not bring the dialysis machine with you. You will pause the procedure, and for this period of time there will be no dose delivered. At the end of the day, don't forget to check the real delivered dose, if it was in the range of the wanted dose. Continuous modalities are commonly used in the early stages of the shock, when the patient needs renal replacement therapy and is hemodynamically unstable. Intermittent or hybrid modalities, because of their effectiveness and short period of time that is required, are commonly used in acute toxicities, metabolic and electrolyte disbalances, and later on, as the patient is more hemodynamically stable, can be used with decreasing frequency of these sessions as the kidney functions are recovering. And for your better picture, patients with chronic kidney failure can attend intermittent hemodialysis session several times per week, and after these sessions, patient can go home. Another important practical consideration is disequilibrium syndrome, which can occur much more commonly with intermittent modalities because of its higher effectivity in shorter time. Plus, in a situation where there is absent autoregulation in CNS vasculature on the background of renal failure, high amount of urea will enter the CNS cells, and after aggressive intermittent dialysis, urea will decrease in a short time, and by osmotic forces, water will enter the CNS, causing cerebral edema, increasing the intracranial pressure, and because of absent autoregulation, this can compromise the perfusion of CNS. And now the differences in anticoagulation. With intermittent methods, we can for short period of time be sometimes without any anticoagulation. However, with continuous methods, this would be much more risky, and the anticoagulation is much more essential. So far, we mentioned anticoagulation several times. Why do we need the use of anticoagulation so much? Our ultimate goal is to prevent any clotting in the extracorporeal circuit. To achieve this, we have several methods. First, we need a solid vascular access, as we mentioned earlier. Second, with the blood flow, you should not go under the 80 to 100 milliliters per hour. This slow blood flow will increase the risk of clotting of the filter. Next, we can use pre-dilution, and the last broad topic is the use of the anticoagulation. If the circuit gets completely clogged, we can end up with situation that the blood being at that time in extracorporeal circuit cannot be returned to the patient and can be lost several hundred milliliters of blood. Thrombosis can occur at the site of the dialysis cannula. This can lead to the loss of the venous access, and we can be forced to secure another venous access. Another problem can be slow formation of clots in the filter capillaries, which eventually decrease in efficiency and we would be forced to change the filter. And now which anticoagulation you should choose? We can see that there exists a comprehensive list of different options, but for the start there are two main players which we should discuss. Starting with the recommended one, that is regional citrate anticoagulation. Citrate is added just after the blood leaves the body of the patient. Citrate then chelates the calcium clotting factor 4 and forms calcium citrate complexes, and this stops the unwanted coagulation outside the body of the patient. After this, the blood arrives to the filter and is cleaned from the unwanted substances. Lastly, before the blood is returned to the patient, calcium replacement fluid is added to the line outside the patient body. This ends the anticoagulation effects and gives the advantage that anticoagulation works only extracorporally, and patients should not be in the risk for systemic bleeding. Citrate and citrate complexes are partially eliminated to the effluent. The rest of the citrate enters the body and is metabolized in the liver, muscles and kidneys, forming bicarbonate and creates metabolic alkalosis. Extreme metabolic alkalosis is avoided by using dialysis solution or replacement fluid with a low bicarbonate concentration. To achieve efficient anticoagulation in extracorporeal circuit for renal replacement therapy, aim ionized calcium between 0.25 and 0.35 millimoles per liter. This can be adjusted by changing the dose of citrate. Remember that you want normal calcemia again in patient's blood. This is done by adjusting the dose of the calcium replacement fluid. Values of ionized calcium in patient's blood and in circuit should be regularly checked. Depends on your local protocol, usually around every 6 to 8 hours. Using citrate regional anticoagulation is now recommended option of anticoagulation for continuous methods. There exists data that this mode provide longer circuit lifetime and fewer bleeding complications when compared to the unfractionated heparin. However, please note that there is yet no data in terms of difference in mortality benefit. Citrate works not only as an anticoagulant but as an important metabolic molecule. Citrate alone is a weak acid, but in a human body is transformed into bicarbonate and causes alkalosis. Roughly 1 molecule of citrate is converted into 3 molecules of bicarbonate, and this will lead to metabolic alkalosis. As we mentioned previously, significant amount of calcium citrate complexes is eliminated into the effluent. So, with increasing dialysate flow, we will increase the clearance of the calcium citrate complexes, and less citrate will enter the body and less bicarbonate will be produced eventually. It is worth mentioning that less functional filter will filter less amount of calcium citrate complexes, and more will enter the patient's body and leads to unwanted metabolic alkalosis. In skilled hands, this understanding can help to control acid-base balance in patients. There are some problems that you should be aware of. First is hypernatremia, as this occurs because citrate is in form of sodium salt, trisodium citrate exactly. Hypomagnesemia should be considered next. Citrate with chelates partial magnesium ions, which eventually ends up in effluent fluid. So in a lot of protocols you can see magnesium supplementation in separate line like CVC with regular ion checks and adjustment of the magnesium supplementation. Citrate intoxication or accumulation can occur if the metabolism of citrate is significantly impaired. This can happen in profound shock states. We can see increase in total calcium because of accumulation of calcium citrate complexes in patient's body, but with decreased ionized calcium, well, because this will be bounded to the citrate. Ratio between these two calciums is best to detect citrate intoxication. Ratio above 2.5 is diagnostic. Worsening metabolic acidosis is another consequence. Why? Because citrate that is not metabolized into bicarbonate is simply acidic. Solid marker for altered citrate metabolisms is increased lactate. This increased lactate signaling altered metabolisms at the level of mitochondria. Citrate infusion in citrate intoxication must be decreased or stopped, and different anticoagulation methods should be strongly considered. Most of our patients will have initially some form of acidosis, and citrate will give us the option to partially help with correction. If we increase the blood flow, we will increase the supply of citrate and cause alkalosis. Complementary to this, we can decrease the blood flow of dialysate fluid, by which we will decrease the elimination of citrate, so eventually more of it will enter the patient's body. By adjustments like this, you can help your patient with acid-base balance. In case of alkalosis, we will do exact opposite. We will decrease the blood flow and subsequently decrease the supply of citrate, or in case we no longer wish to decrease the blood flow, we can increase the dialysate flow and the elimination of citrate. You can see some rough estimations for your better picture what you can expect, but these are just estimations, nothing specific you should hold on to. If the previous adjustments did not lead to improvement, consider changing of hemofilter. Now imagine you have average septic unstable patient with acute kidney injury that slowly needs renal replacement therapy. You've decided to provide a continuous method, and for anticoagulation you have decided for the recommended option, which is citrate. Most important number to remember is the dose or the dialysate flow, that is 20 to 25 mL per kilo per hour. And then remember that the ratio 1 to 20 should be done to calculate the blood flow. Just know different units and you will be 100% golden. In different hospitals, you can see slightly different initial settings. Your local protocols can do this hard work for you, so you much probably don't have to remember all these numbers. It's just for you to have some idea. Commonly, 4% citrate is used with the aim to produce concentration in the extracorporeal circuit around 3.8 millimoles per liter as a starting baseline. Unfractionated heparin is the most widely used type of anticoagulation. It has rapid onset of action with a half-life about 90 minutes, however it can be prolonged up to 3 hours. This forces us to monitor effect of heparin. APTT is most commonly used. This is quite a standard of practice as the effect can be commonly unpredictable. Sometimes you can see priming of the circuit with heparin by adding heparin into the saline priming solution. By doing this, heparin molecules should theoretically adhere to the circuit tubing before the patient is connected to it. Heparin is administered most commonly pre-filter in the so-called arterial access. We can see different protocols. Commonly used strategies is single loading dose followed by the continuous maintenance dose. In case of intermittent hemodialysis, the maintenance infusion is usually stopped around 30 minutes before the end of the session. This does not employ for continuous methods which do not simply have any end of the session. Protamine can be given post-filter to form regional anticoagulation. Heparin causes systemic anticoagulation that can lead to unwanted systemic bleeding. This can be antagonized by protamine if needed, but remember, use of protamine is not without its own risks. Use of heparin anticoagulation carries specific complication named heparin-induced thrombocytopenia. Checking platelet counts on a regular basis can help with detection. Remember that this is a hypercoagulate state that needs to be addressed ASAP, and stop of the heparin infusion immediately and giving a different anticoagulation, for example argatroban or bivalirudin, is essential in the management. I would like to mention few details about pressures that can be seen on display of every dialysis machine. The access pressure is the negative pressure that aspirates blood from the catheter to the filter. Very negative pressures could mean that the lumen is up against the wall. In this situation, gentle positioning of catheter or switching of the lumen can be tried. Patient can be as well dehydrated. In this situation, consideration of decrease of the ultrafiltration or blood flow is in a place. Kinking and clotting of the line should be addressed as well. Venous pressure is the pressure that returns blood back into the vein through catheter. Very high pressure means the same as previously. Bad position, some kinking, clotting, and theoretically it could mean that the catheter is in an artery, but this hopefully was noticed during cannulation. Filter pressure or transmembrane pressure, if this pressure is high, it usually signaling that the filter is starting to clot. About all this pressure care our skilled nurses. Most of the time you probably don't even know that there are some minor problems, but it is a good practice to be aware of them. In case you know, they call you and ask you what they should do. And don't hesitate to ask them if something is not fully clear for you. They can be super keen and helpful. As the renal replacement therapy is not without a risk, let's go through some. Complications associated with venous access as a pneumothorax or infection can be related to the access site. Systemic bleeding, particularly associated with systemic type of anticoagulation like unfractionated heparin, is crucial to consider, especially in patients after, for example, surgery or trauma brain injury. These patients are vulnerable for bleeding complications. Anemia can be intensified due to initial dilution, bleeding, or loss of the extracorporeal blood by clotting of the circuit. Note this advanced knowledge that convective methods cause somewhat more damage to the platelets. As renal replacement therapy cools down the patients, hypothermia can obviously occur. And on the other hand, fever doesn't have to appear in patients because they are simply cooled. Hypotension can be due to hypovolemia, for example. Air embolism is potential complication. This is prevented by using bubble traps situated post-filter. Dialysis disequilibrium syndrome that we already described previously can be seen much more often with intermittent methods. And this brings us finally to the end of the session. I hope you've enjoyed and learned something new. In the description you can find several links to handy sources that are worth reading for additional knowledge. If you have any questions, leave a like and comment, I will definitely answer. Thanks for watching and steady hands for cannulation.